Welcome everyone to the eMedica AKT MRCGP AKT High Yield Revision Webinar 3 for the April 2022 exam. So in terms of the format, we're going to go through 15 exam style questions covering key topics. So I'd like you to write down on a piece of paper at home the numbers 1 to 15 so you can keep track of the question numbers so that when we go through the answers and explanations, you can follow which question I'm talking about. And after we've done questions, we'll go through rapid reviews. And I'll also go through some examples of some keywords, things that might help you in exam technique, because doing well in the AKT is part putting the work in and covering the key topics, the knowledge base. You've got to know the stuff, but it's also part exam technique, picking out keywords, understanding what is the examiner actually testing in this question. So we're going to split this session into 3. First part, we're going to do 5 interactive questions, some stats, some clinical, some admin. So we'll do 1 question at a time in part 1, just 5 questions. Part 2, I want you to get used to what does it feel like to keep up to the optimum pace if you want to finish the exam and have about 10 minutes left to go over any you're unsure of. So what we'll do is we'll do a timed mini-mock of 10 questions. So you'll see 10 questions, one after the other. Just write down your answers at home, but every 55 seconds, the questions will automatically move forward, whether you're ready or not. Then we'll go through each one at a time, go through the answers, explanations, teaching. And then part 3, we'll look at how to make the most of the 7 weeks or so that we've got between now and the actual day of the exam. So, how to maximize this crucial period of your preparation. And then there'll be a chance to ask any questions on anything. Any questions that haven't already been addressed by the team, they'll be picked up in the Q&A. Okay, so are we ready? Shall we begin? Let's get into it then. Here we go. Here's question 1. You'll have 55 seconds and I'll launch a poll. You won't see me during the question. Here we go. Okay, great. I'll stop you there. So very interesting. We've got a big spread of answers. The 2 most popular answers are A and C. All right. But every single answer has had a good proportion of doctors selected. Okay. So what we're looking at here is an audiogram, and it's really important. Any question that's got a picture attached to it, make sure you look at both the picture and read the scenario, because if you just focus on one or the other, you will often, the way the questions are written, you will often get it wrong if you just focus on one or the other. So if we read the scenario first, it shows a 38-year-old engineer. So that's someone young, okay? And they're having an annual check as part of their work. There are certain industries where if you're working in there, you get like an annual health check, okay? And then if we look at the scenario, what we're seeing here is we've got red circles and lines, and we've got blue crosses and lines. What's interesting, do you notice that there are no brackets, okay? So brackets are used to show bone conduction in an audiogram. Circles and crosses are used to show what? Air conduction in an audiogram. Okay, so we don't have any bone conduction shown. That's a big clue that this is going to be a sensory neural issue, because if there's a conductive loss, you'll see both bone conduction and air conduction shown in the audiogram usually. So that's a useful clue. It can help us narrow down our options. Okay, so the correct answer is A, that the hearing in the right ear is mostly in the normal range. Now, some of you might be wondering, well, which one is the right ear? That's part of the test here, okay? So the right ear is always, in standard audiograms, it's always shown in red, okay? So refer red, refer right. So this is the right ear, and can you see, it's mostly in the normal range, okay? I'll show you the normal range here, okay? So essentially, anything in this range, okay, so anything above here is considered normal. Like imagine this is the line, anything above that, that's normal. in this range here, where it's yellow, it suggests there's some mild loss. You can see, so mostly it's in the normal range. Just at the very high frequencies, it just dips into a mild bit of hearing loss. So do you see, the hearing the right ear is mostly in the normal range. Most of it's in the normal range, okay? This is mild loss. Once you get here, you've got more significant loss, and this is like really severe loss, okay? Now, the other really popular answer was C, that this is consistent with a conductive hearing loss in the left ear, all right? This is the left ear, and we've got significant loss in the left ear here, but we can't say it's a conductive loss, because for that to be the case, we'd have to see what the bone conduction's showing, and the bone conduction is not shown here. Okay, so we couldn't say C. All right. Couple of other answers that were not as popular but still popular were D and E. So that this is consistent with a conductive loss. Well, we can eliminate conductive because bone conduction not shown. And then E, both ears show mild hearing loss in the low frequency range. Actually, if you look in the right ear, these are the low frequencies, completely in the normal range for the low frequencies. So only in the very high frequencies, the right ear has very mild loss. Whereas you can see in the left ear, okay, you can see that it's got mild loss even at low frequencies, and it's got significant loss once we get into the higher frequencies over here, okay? So audiograms, bone conductions will be shown with brackets, either square or triangular. So here's an example of what a conductive loss would look like. Okay, you can see, so you've got normal bone conduction and then reduced air conduction. So it's suggesting that there's a gap. There's a difference between the bone conduction and the air conduction. This gap, that tells us that there's a conductive loss. Okay, in this case, is the conductive loss in the left ear, the right ear, or both ears? Type into the chat. Yeah, absolutely both. Can you see? It's an example where both ears have reduced hearing sensory-neurally, but bone conduction is normal. So it's an example of bilateral conductive loss, okay? This is an example of the most common type of sensory-neural hearing loss. In a sensory-neural hearing loss, typically they won't bother showing the bone conduction. So you'll just see the circles and the squares. And as I mentioned, the right ear is always red, the left ear is blue, okay? So anyone know what type of sensory-neural hearing loss is being shown here? This is presbyacusis, which is the most common cause of sensory neural hearing loss. It's the hearing loss of old age. It's typically bilateral, and you often see it's high frequencies that are significantly lost. Low frequencies tend to be normal, okay? The second most common sensory neural hearing loss is noise-induced hearing loss. That can be bilateral, but quite often, depending on the cause, it'll be unilateral. Good example, someone who's been in the army and fired rifles a lot, they'll be holding the rifle closer to one ear. So you'll see one ear has significant loss, more so than the other ear, okay? Let's move on to question 2. Here we go, men's health. Okay, great. Again, every single answer has been picked, but there are 2 that are really popular, and they are B and D. Okay, so option B and option D are the 2 really popular options. Okay, so the correct answer is D. Treat with levofloxacin 500 milligrams, 10 days, once daily. Okay, so before we get to why this is the right answer, there's actually a 2-step question, which you often see in AKT, that some of the harder questions are actually testing the mark is for the second step. You can see the mark here is for management, right? The first step here is working out the likely diagnosis. And that's going to help you get the right management. So let's do that as a question. Before I explain this, write into the chat, what do you think the diagnosis is? What if this question had the same scenario, and instead of asking what's the most suitable management, it said, what's the most likely diagnosis? the single most likely diagnosis? Type that into the chat, because you could get that exact same question. So we've got a range of options. Most people have said epididymitis. Some people have said prostatitis. And then we've got, let me see if anyone's got anything different. Someone suggested that it could be gonorrhea. Yeah, that seems to be the main things that people have thought about. Okay, good. So, has anyone got anything else? Has anyone thought it was torsion? Okay, good. Okay, so that's good. So most people thought it was epididymitis, which is the right answer. That's what this fits with, right? Okay, let's look at why. Okay, and something that you might find useful in terms of technique, there's different length of questions in the AKT. A lot of questions will be 3 or 4 lines and then the question. Okay, 3 or 4 lines. You'll get very few that are 2 or less lines, but you might get the odd one. Okay, but you get some that are really long, like this: 1, 2, 3, 4, 5, 6, 7, 8 lines, then the question. So for long questions, a useful tip is to start at the end. What do I mean by that? If you click next and you come onto a screen that just looks really long, full of information, just look at the very last line, which is the actual question. So in this case, it's the most suitable management. Glance at the answer options. Then when you start reading from the top, you'll know what to watch out for. So you can see there's different answer options here that are all to do with management. So you can think, okay, things that might make a difference to management, apart from what the diagnosis is, do they seem really, really unwell, septic, acutely unwell, such that they might need admission? Because even with something infective like epididymitis, if someone had a high temperature and they're really sweating and they're really unwell, their blood pressure's way off, and you think they might have got sepsis secondary to that infection, you can see then the answer might be to admit them, but reading the whole option is important. It still probably wouldn't be admit to hospital for surgical management if you thought someone was septic. It might be admit for IV antibiotics and further assessment, you see, but it might help, right? Okay, so look, they're 52, so relatively young. 4-day history, that's important, right? So, this is not a chronic problem. This is something acute, yeah? And they've got swelling on one side, right scrotum. Pain's not changed much, and he's been taking ibuprofen, which helps. No trauma. And then he recently had a UTI, not been sexually active in the last month. We've got mild tenderness and swelling, and Pren sign is positive. That's another really useful clue. What's Pren sign? Type into the chat. What is it? What would you do? So Pren sign is where you elevate the scrotum, and if the pain goes away, okay, is that Pren positive or negative? So when you elevate the scrotum, the pain goes away. That means that it's probably going to be epididymitis. If the pain doesn't go away, that would fit more with torsion. Something else that would fit more with torsion, a younger patient, okay? More acute, and that it's exquisitely tender, not mild tenderness. Do you see? Those are some of the things that would give you a clue. So when you put all of that together, this fits with epididymitis. So then the next thing is to read, next bit of technique is to read the whole answer option. As I said, not just to look at admit to hospital and move on for surgical management. That would fit if it was torsion, right? When might you think treat with ceftriaxone and doxycycline? Well, this guy, epididymitis, could be secondary to an STI or secondary to a UTI. This guy recently had a UTI. That's more likely. He's not been sexually active for a long time. That's less likely for him. You see, if you thought it was from sexual activity, things like chlamydia, gonorrhea, then you might be looking at some of these options. Do you see? Okay. And so that's why the right answer is D. So let's go through the guidance on it. So how does epididymitis present? Usually it's fairly gradual, like over a few days, not very acute like torsion. It's usually painful and has some tenderness, but it's not exquisitely tender in the way that torsion is. There'll be a palpable swelling. Usually there'll be overlying erythema, and then Pren sign is usually positive. So that's where you elevate the testes by elevating the scrotum and it relieves the pain. That's Pren positive. So you'll see that in epididymitis. In torsion, Prens will be usually negative, i.e. the pain doesn't get better. In fact, they usually won't let you hold it for long enough to elevate it because it's so painful to touch. And in terms of management, if they're really unwell, you think that they might have got septic, then you might admit, not for surgery, but for medical management, IV antibiotics, for example. Then depending on what you think might be the cause of it, you might refer to gum if you think it's the sexual variant, so they can have a full sexual health screen, ideally within 24 hours. Otherwise, we can treat it in GP. And we treat based on the likely cause. So if we think it's the STI variant, gonorrhea is a common cause for that. And we might think about ceftriaxone plus doxycycline plus or minus azithromycin. So often patients will often also, if someone's got gonorrhea, we want to look out for things like chlamydia. But then if you think that it's more likely to be an enteric organism, i.e. a UTI variant, low risk for STI, then the options are either ofloxacin or levofloxacin. But ofloxacin is a 2-week course. So if I go back to the answer options, you can see, when would you admit for surgical management if you thought it was torsion? That's unlikely with this history, right? When would you go for this one if you thought it was an STI? That's less likely for this patient. This one, right drug, but look, reading the whole question, the whole option, single dose. Ofloxacin isn't a single dose. It's a 2-week course, okay? What do we use as a single dose? Azithromycin, you might use as a single dose, not for this, okay? So the correct answer is D. Now, do you see here how it's not just the knowledge, which is to work out what's going on here and know the guideline for management. Even if you've got the knowledge, if you just see ofloxacin and don't read this bit, you could pick this and still get it wrong. So that's technique, okay? So let's move on to question 3. I'll stop you there. Wow, that's really interesting. Almost exactly split between A and B. No need for antibiotics or offer a delayed script. These two almost exactly split, both very, very popular. Just under half picked each of these. And then just a very few people picked either C or D. So again, there's 2 steps to this. The first step is from reading the scenario, working out what is the FeverPAIN score, as that's the criteria that I mentioned here. So type into the chat, what do you think the FeverPAIN score is here? Because of course, if you get that first bit wrong, it'd be very easy then to not get the full answer right. Okay, so what do you think the FeverPAIN score is? So we've got ranging from, some people think it's 1, 2, 3, 4. Perfect. So we've got the full range. I can see why there's a spread of answers then. Okay, nobody thought it was 0. Okay, good. So we've got 1, 2, 3, 4. The actual FeverPAIN score for this patient is 3. So first step is working that out, then knowing what does the guideline recommend we do for a FeverPAIN of 3. It recommends offering a delayed script. And then what will it be for? Well, if they don't have any history of penicillin allergy, then first line would be Pen-V. There's no mention of any penicillin allergy, so that's why the correct answer is B. Offer a delayed script for Pen-V, okay? Not clarithromycin. Clarithromycin might be suitable if they had a history of significant penicillin allergy, which they don't have, okay? So why is it not A? Well, because the guideline says for a FeverPAIN score of 2 or 3 that you should consider a delayed script, okay? And Pen-V's first line, and they score 3. So that's why it's B rather than this. This would be if they scored 0 or 1. So let's look at where they get their 3 from. First thing is that they've got a 2-day history of sore throat, okay? So which part of FeverPAIN does that relate to? That relates to the A, i.e. attending rapidly. They've attended within 3 days of symptoms. So they get a point for that, okay? And then here, mum says that she had a fever of 31.8 degrees earlier in the day. So they get a point for that, okay? That's the fever in FeverPAIN, all right? Even though they're afebrile now, if they've had fever within the last 24 hours, and you just take the patient's word for that, okay? Or in this case, the parent, okay? It's within 24 hours, so that gets a point. So they're on 2 so far. And then the tonsils are inflamed, so they get a point for that. That's the I, inflamed tonsils, okay? You can see they don't get one for P. P is for pus on the tonsil. They don't have any pus, okay? Otherwise, they'd get another point. And then they don't get one for the N. The N is no cough or coryza. You can see if they've got a history of runny nose, they don't get a point for N because they've got coryza. It's not 1 point for each. Otherwise, you'd get a possibility of even more points, okay? So it's a maximum of 5, isn't it? Okay, so if they don't have a runny nose and they don't have a cough, they'd get a point. But they've got a runny nose, so therefore they don't get a point for the N. So that's why it's 3 and not 4, okay? So the correct answer is B. So let's go through fever pain. We've just sort of covered it really in going through that. So the fever is fever within the last 24 hours. So it's knowing that bit, that it's not fever now when you examine them. If they've had fever within the last 24 hours, that's a point. P is for pus on the tonsils, on the back of the throat. A is for attending rapidly. So within 3 days of the symptoms starting, they attended within 2 days. I is for inflamed tonsils. So they might not have pus, but, you know, puffy, red, okay? And N is not having cough or coryza, i.e. no cough or runny nose. If they've got either one of them, they don't get the point. They have to have lack of both to get a point. So 0 or 1, it's very unlikely that they've got a bacterial infection. It's very unlikely to be streptococcal. No antibiotics. 2 or 3, there's a good chance that they actually have. So you consider a delayed script. Why? Because they may still get better on their own, but you tell parents, you know, I'll give you the prescription now. If they get better in the next day or 2, fine. If they're still not improving, you could start taking them. You don't have to come back again. 4 or 5, consider starting it today because it's a high probability that it's a bacterial infection. And first line is Pen V. If they've got a history of allergy, then it's clarithromycin or erythromycin. Okay. Question 4, admin. Okay, thank you very much, everyone. I'll stop you there. Okay, so 3 popular answers are C, D, and E. Okay, so these 3 are the popular ones. Very few people picked PALS because that's to do with the hospital, and they've contacted you about a GP record. Can you see? So PALS wouldn't be relevant for that. Okay, and then quite a few people picked A actually. That advise that confidentiality remains after death. So something really important about that. This is incorrect. This bit is true that confidentiality does remain after death. The bit that makes it incorrect is that advising that you can't access the records. And that's because if they're the next of kin and or the executor of the will, and they've got a legitimate reason to access someone else's records who's passed away, you can see this is the patient's father's passed away, and they've got 2 sort of relationships that would give them a legitimate interest. So one is being next of kin, one is being the legal executor of the will. They've got both, okay? And they've got a reason why. They think that there was negligence, and so they want to take legal action, okay? So it's knowing then which is the relevant act. So the correct answer is E. So if someone wants to access someone else's record who's passed away and they have a legitimate interest, then the act that relates to is the Access to Health Records Act 1990, okay? So let's look at 3 important acts that you need to know about and which ones relate to which. So the Data Protection Act 2018 is the most common one that we'll see. And that's what people use if they want to access their own information. So for example, let's say you wanted to get access to information in your medical record, whether in a hospital or in a GP setting, you could put in what's called a subject access request under the Data Protection Act 2018, and then they give you access. Okay, either provide you a copy of the information or allow you to go and have a look. Okay, so if it was in hospital, you apply to the hospital. If it was in GP, you apply to the practice. Okay, Access to Medical Reports Act 1988 is for companies that want to access information about their employees, and that's usually to do with occupational health issues. And then the Access to Health Records Act 1990 is where someone wants to access the records of someone who's passed away, and they're either the next of kin or the executor of the will and have a legitimate reason to do so, like they think there was negligence. Okay, and then stats. Here we go. Okay, I'll stop you there. So there are only two answers that are particularly popular. So the most popular answer is D, Doncaster, and then quite a few people pick B, Bradford. Okay, so it shows mortality for parts of Yorkshire. So these are all different parts of Yorkshire. This is Yorkshire, the region. This is England as a comparator. Okay, and the question is, which area has the worst mortality rate for women under 75? So the first thing is, once you realize that you're looking at worst mortality for this specific subsegment, not mortality for everyone, but women under 75, is just firstly making sure you're looking at the right line. So here, under 75 mortality rate from all causes, women. Do you see? If you looked at women, female here, but you looked here, that's specifically only cardiovascular deaths. People that died of a heart attack, of a stroke, you see, cardiovascular only. Whereas this is all-cause mortality. Of course, this would also include people that died of cardiovascular, but it also include people that died of cancer, of road traffic accident, of anything. Do you see? So that's what the question said. The worst mortality. It didn't say the worst cardiovascular mortality. So those of you that picked Bradford, why might you have picked that? Because if you look at cardiovascular mortality in women, Bradford has the worst rate. It's worse than Doncaster. You can see 65.6. Whereas if you look here, there's no maths, there's no calculations. It's literally just interpreting the data. So finding the right line, read along, and then reading carefully. Worst mortality, highest number, right? The lower the mortality, the better. So the worst mortality is the highest number. So all you need to do is find the highest number on this line, and that's it, Doncaster. Well done. Most of you got that right. But those of you that picked Bradford, either you were looking at women specifically dying of cardiovascular causes, or you might have looked at all causes for men and women, persons here, men and women. You can see Bradford does have a higher rate than Doncaster when we look at men and women. That's because the men had a much higher rate in Bradford than Doncaster. So this is the new style data interpretation question. Uses real life data. This is pulled from Public Health England. I got this data, okay? It's not any calculation. It's just getting familiar with this type of data so that you can interpret it quickly. So other types of data interpretation questions that there's a lot more of now. Things like prescribing data, incidence prevalence between different regions, public health data, mortality rates. You do still get the interpreting research type questions. So, things like this. This is prescribing and age ranges. Okay, this is prescribing. This one's age ranges. This is called a quinary graph. You split people by 5-year age bands. Okay, this is again looking at infant mortality rather than mortality. All right. This is looking at COVID sensitivity and specificity and how to look at pre and post test probabilities. It's called a leaf plot. It's called a Kate's plot or smiley face graph, a visual way to represent risk, things like that. Okay. So if you found this way of learning helpful, just to highlight that this format of doing a high yield question, looking at the poll, then looking at both the knowledge side, reviewing the guideline, the topic, but also looking at why might you have got it wrong, even if you knew it, keywords, how it's worded, specific things. If you found that helpful, you'll find our AKT Masterclass webinars running later on in March helpful. So they're 3.5 hours each. They run live just like this, but you can also get access to the recording for a month afterwards to go over it again closer to the exam. So it's very interactive like we're doing today. And we have one for stats, 3.5 hours, all the key stats topics that you need done in one evening. Okay. You get a course booklet the evening before, and you'll get further teaching and links to read after the course. Organization domain organized, all the key admin topics. So stats is on the 22nd of March, admin is on the 23rd of March. And then we've got 2 high yield clinical grammar, because clinical being so big, you can't fit it all into one evening. So what we cover here are specifically the clinical topics mentioned by RCGP examiners in their examiners reports in recent years. These topics are frequently retested. So the second one, a large part of that are picture questions, which people often struggle with. So things like, dermatology, ophthalmology, ENT, things like spirometry graphs, flowmetry graphs, a lot of things like that, audiograms, picture-based questions, basically, that people often struggle with, alongside any clinical topics that have been mentioned in examiners' reports. So it's exactly this format. We do questions, then go through the revision. Okay, so they're the 22nd, 23rd, stats admin, 29th, 30th is high yield clinical grammar 1 and 2, 7 p.m. to 10:30 each evening. So stats, we'll cover all the key stats. We've had lots of people get very, very high scores in stats, and you get yourself a good score in stats and admin, it helps you get away with, say, 70% in clinical. So you can get 80% plus in stats and admin. So stats, 45 questions, but 60 plus topics, because sometimes after one question, I'll talk about 3 or 4 topics. Admin, 45 questions, 60 plus topics. And then clinical grammar 1 and 2, over the 2 evenings, 90 questions, 100 plus topics. Okay, so we're going to move on now to the mini mock. We're going to do 10 questions, one after the other. You won't see or hear me throughout. Just write down your answers at home for all of them. Okay, and then we'll go to the answers at the end. So you get used to the optimum pacing to finish for standard timing with 10 minutes left. So every 55 seconds, I'll move on. Here we go. Okay, well done, everyone. So we're going to go through the answers. First one, palliative care. This was highlighted in the latest examiner's report, again, as an area that people often have struggled with over the last 5 years. Okay. By the way, every single AKT will always have at least one and often two or more prescription calculations, drug calculations, dosage. So a common one is a cancer pain one, and another common one is a child health one, a pediatric dosage calculation. Okay, so the one that was not very popular was D. All of the others, lots of people have picked. So the correct answer here is C, 80 milligrams. Okay, just over half of you got that right, so well done. But why might have some of the others got the other options here? So first thing here is reading carefully. He's on morphine sulfate, modified release, 120 milligrams twice daily. If you missed this, that is on twice daily dosing, then you might think he's only on 120 milligrams of morphine. Okay. In which case, if you're converting from oral morphine to diamorphine in a syringe driver, you divide by 3. Can you see? So those of you that picked 40, what you probably did was you missed this bit. You missed that he's on twice daily, and you thought 120 divided by 3 is 40. That's where you got it wrong. Those of you that picked 60, you might have again seen 120, missed that it's twice daily, and then thought, okay, I'll divide by 2 to get to 60. That's if you're dividing, if you're going to put them from oral morphine to injection morphine, not diamorphine. Okay, so parental morphine, injection, subcut, IV, okay, IM, you divide by 2. But for diamorphine, it's divided by 3 from the oral. So the first thing is just reading carefully. What is their total oral morphine usage? It's 240 milligrams in a day. You see, so 120 times 2 is 240. You divide that by 3, that gives you 80 milligrams over 24 hours. Okay, so 120 milligrams twice daily is 240. The conversion from oral morphine to subcutaneous diamorphine, divide by 3. So 240 divided by 3, 80. Remember that when you're doing the AKT, there is an on-screen calculator. It'll be here in the top left corner. When you click it, a little calculator comes on the screen. Okay. So syringe drivers, really useful in a palliative care setting to be able to give good continuous pain control. Situations where it might be useful, because if someone can still take orals and we can give them, you know, something like modified release and control it, then orals have lots of advantages. But often patients who are very close to the end of life, they can't take much orally, but we still want to give them good pain relief. Certain patients with certain cancers where swallowing becomes a difficulty, like esophageal cancer, for example, a head and neck tumor, you know, that can be a problem. And then sometimes with other types of cancers where they've got significant vomiting. And so oral, again, isn't ideal. You know, these might be situations where you might use a syringe driver. So what you do is you calculate the 24-hour oral morphine usage, including any breakthrough doses, okay? And then all you do is, once you know what they're using, you just, if you're going to convert to morphine, which you can also give via syringe driver, you divide by 2. If you're going to give diamorphine, you divide by 3. Okay, so examples. If someone was on 60 milligrams modified release twice daily, 120 milligrams in total, putting morphine in a syringe driver, you just divide by 2, so 60 milligrams. Putting diamorphine, you divide by 3, so it's 40. This patient was on 240. So divide that by 3, it's 80. You had a patient on very high doses, 600 milligrams of oral morphine, that'd be 200 of diamorphine, and so on. Okay, we've got both parents are carriers for hemochromatosis, i.e. they've got one faulty gene, one normal gene. They're carriers, they don't have full-blown disease. And what they want to know is what's the risk that their children will have the disease? Okay. So first of all, it's knowing what type of inheritance does hemochromatosis follow. Hemochromatosis is autosomal recessive. And so if both parents are carriers, the risk of a child having the disease is 25%. Okay, 25%. So why might people get this wrong? Not knowing the way that hemochromatosis is inherited, or missing that the question was asking about the children having the disease, not becoming carriers like the parents are. Okay. The second part of this, can you see, every question in the AKT will have a title just like this. EMQs come in sets of 2, 3, 4, or 5. So this is genetics 1 of 2. This is genetics 2 of 2. The answer options won't change, just the question will change, okay? So here, It's what's the risk that any children that have are carriers like themselves, not having full-blown disease, but become carriers. So the risk is 50-50, 50%, okay? D, 50%, okay? So autosomal recessive. So this would apply not just to hemochromatosis, but also things like sickle cell. That's also autosomal recessive. What else? Type into the chat other diseases that are inherited in an autosomal recessive way while I explain it. So look, we use hemochromatosis as the example. See, these parents, they've got one hemochromatosis gene, the abnormal one, and one normal gene. So we'll call the hemochromatosis gene the H gene. We'll call the normal one the N. So you can see they're both HN, HN. Now you get one from your mum, one from your dad. If you're unlucky, you'll get the H from mum and the H from dad. So now you're HH. This person will have hemochromatosis, full-blown disease. Do you see there's only a 1 in 4 chance that that happens? Whereas if you get a H gene from either mum or dad, and there's a 50-50 chance of that happening, and a normal one from the other parent, you become HN, just like your parents. 50% chance you're a carrier, but don't have full-blown disease. And then you could be lucky, 1 in 4 chance, you get the normal one from mum and the normal one from dad, NN, you'll be, not only will you not have disease, you won't be a carrier, and there's 0 chance you could pass it on to the next generation, okay? So 50% you become a carrier, 25% you have full-blown disease, 25% you're healthy non-carrier. And so in terms of modes of inheritance, I've listed here some of the more important or relatively more common for the UK population modes of inheritance. So, you know, autosomal dominant, think about things like Huntington's, neurofibromatosis, Marfan. Autosomal recessive, we talked about sickle cell. We've just done a question on hemochromatosis, CF, PKU. We screen for these in the National Newborn Screening Program. Then we've got things like that are X-linked dominant or recessive. Don't forget polygenic or multifactorial, where there's more than one thing being involved. So things like neurotube, pyloric stenosis, and then chromosomal. So you can have trisomies, trisomy 21 being perhaps the most famous one, down. Turner's is a deletion. So we've got 45X, so 1 missing. Klinefelter's is an insertion, 47, because we should have 46, right? So that's XXY. Okay. Right. So this is the first multiple best answer that we're doing. You can see there's 2 options, which 2, and then this is also challenging because not only is there 2 options that you have to get the mark, it's also negatively framed. Which 2 of the following would not be recommended as part of the diagnostic workup for this patient? The first thing to think about, what do you think the diagnosis is? Looking at all of this, what do you think the diagnosis is? Nearly everyone has picked H, and then there's a big split in terms of the other option between A, D, E, and F. Lots of people have picked different versions of those, okay? But almost everyone picked H. Be honest, let me know in the chat, how many of you picked H because you just haven't heard of it before? And that's actually not a bad technique. If it's asking for something that you wouldn't do, and you think, if I've never done this in all my years as a doctor, it's probably not something common. If you're really not sure, that's not a bad way to pick something that you're not probably going to do much. Do you see? That can actually be quite useful, right? So which would not be recommended? So what do you think the diagnosis is, first of all? So the options we've got, some people thought it was PCOS, some people thought it was premature ovarian insufficiency, i.e. premature ovarian failure. Some people thought it was early menopause, okay? So you can see range of things in terms of what you think the diagnosis is. That first step is important because it's going to help you get the second step. So the correct answers are A and H. Now, something very important. Multiple best answers, the way that they're marked in AKT is really, really strict. You have to get them both right to get 1 mark. Now, lots of you got H, but didn't get A. You picked one of the others. You get no marks at all for getting one of the 2 right. There are no partial marks in AKT. You either get 1 mark, you got both A and H, or you get nothing at all. There's no partial credit, okay? So the diagnosis is premature ovarian insufficiency. So well done to all of you that got that as the sort of diagnosis. First of all, what we're looking for. She's under 40. That's one of the things we look for. Had erratic periods. So look, sometimes, you know, she's having them and they're sort of a long gap between them, 6 to 8 weeks, but then look, no periods at all for a period. Then they spontaneously restart, okay? And then she's also got some changes in mood, all right? Not on any medication, otherwise well, okay? So which 2 would not be recommended as part of the diagnostic workup? Pelvic examination is not recommended for if you think someone's got premature ovarian insufficiency, you wouldn't routinely do that. AMH testing is not routinely recommended, okay? So when to suspect it? Under 40, not on the combined pill, and they've got sort of menopausal type symptoms. Now, that could include that their periods are a bit erratic. They have no periods for a period. They're infrequent. Sometimes they just come back on their own. You might see raised FSH levels, okay? So 2 samples, at least 4, sometimes up to 6 weeks apart. You want to see that they're 30 or more, okay? And then other things you might do. You might test any of these, but what you wouldn't routinely do is do a pelvic examination or use AMH as part of your diagnostic workup for this, okay? Now, it'd be different if, for example, your patient was much older and, you were thinking about other things. You might, like, if you thought that I might be worried about a cancer, okay? You had an older patient and they'd had maybe periods had stopped for a while, and then they suddenly had bleeding and they were postmenopausal, then you might be worried about, then you might want to do a pelvic exam. But here, that's not what we're looking for. The likelihood that this is a cancer, very low, okay? It doesn't describe that they've got pains. What it describes is exactly what we'd expect to see in premature ovarian insufficiency, okay? Right, question number 10. So this is part of the admin domain. One part of that is understanding and knowing some of the medical legal issues, some of the GMC guidance, and that was something that was highlighted again in a recent examiner's report that people often struggle with. But again, exam technique is important here because part of it is also about knowing about the GP contract, okay? So correct answers, B and F. Again, you need both to get the mark, okay? And lots of you picked B, but actually the most popular answer was E, not F. So not that many people got a mark for this, because remember, if you get one of the 2 right, you get nothing, okay? So a lot of people picked E, gifts with the value of £100 or more needed to be reported. So let's look at why you might have got that. Be honest, again, let me know in the chat, how many people read this, not as GMC guidance, but as GMS? GMC, the General Medical Council, tells us in which situations we can and cannot accept gifts. There's a whole section in the ethical guidance on financial issues around being a doctor, because we're in a position of power, in a position of privilege, okay? And it's important that we don't abuse that power, right? The GMC does not state at all anything about the value of those gifts. However, those of you that work in a practice that holds a GMS contract, GMS is one of the 4 NHS contracts, GMS, PMS, APMS, PCLMS. These are the 4 NHS GP contracts. Every GP practice in the NHS has one of those 4 contracts. GMS is the most common. The GMS contract, which is nothing to do with the GMC guidance, which is what this question is about, specifies values that they consider to be high value gifts, and you have to record those in a register. And some of you might have read £100 because that is the value of a high value gift, but that's GMS, not GMC. Just the importance of technique, reading carefully, as well as knowledge, okay? So correct answers, which 2 are correct? Unsolicited gifts from patients or relatives may be accepted in some situations. You didn't ask for it. It's not going to alter the management or the services you provide. It's not going to be considered that you're taking advantage of someone. Let's say you've got an unsolicited gift. You didn't ask for it, but that patient's got advanced dementia. I'm not going to accept that gift because I don't know that they're freely given it. They might feel that they have to give it. Let's say I've done a home visit or something. They might feel, oh, I have to pay because it's a visit, which of course they don't have to pay. But you see, so I wouldn't accept that one because it might be seen as I'm taking advantage of someone who's got dementia. Do you see? So in some situations. And then the GMC doesn't set any maximum value of gift that can be accepted. All right. Whereas in the GMS contract, there is a value, and that value is £100. All right. So the GMC guidance tells us when we can and can't accept gifts. So you're not allowed to encourage a gift or pressure a patient to make a donation, even if it's to a good cause. You shouldn't pressure someone to make a donation. You're not allowed to alter the management that you give them or the services offered based on a gift. Otherwise, it becomes a bribe. Whereas unsolicited gifts can be accepted in some situations. So it's not going to be any of these, and it's not going to be seen as you abusing your position of trust. It's not going to be seen as you're taking advantage or there's any conflict of interest. Whereas if your practice happens to be a GMS, like I have to abide by this, as do all of us that have a GMC license to practice and have GMC registration. Only doctors that work in a GMS practice have to abide by the GMS contract. Okay, nothing to do with the GMC. Now that contract does say that if you accept a gift worth £100 or more, doesn't say that you can't accept it. It just says that you have to record it in the register of gifts held at the practice. So every GMS practice has to have a register of gifts. Okay. Now, as registrar, you probably don't get the high value gifts. Ask your trainer. Okay, especially around Christmas time. It's quite common. Patients often do give gifts. Okay, question number 11. So, musculoskeletal, again, often some parts of that people struggle with. So, as well as some of the diseases, think about things like drug monitoring for disease-modifying anti-rheumatic drugs. That was mentioned in a recent examiner's report. Okay. Great. So key thing here is that the small joints, plural, of hands and feet are affected. Okay. So the correct answer here is to refer to be seen within 3 working days. Don't wait for the test results. We've ordered results. We've given analgesia so that we can, do something about symptoms, because someone with persistent synovitis is very likely to have pain. Okay. But it's important to understand that this is what we would consider like a very urgent referral. Okay. So suspected rheumatoid, anyone with suspected rheumatoid should be referred within 3 weeks. That's the normal referral timeline for suspected rheumatoid. But who to refer even more urgently, i.e. within 3 working days? If the small joints of the hands or feet are affected, this patient was both. If multiple joints are affected, or if they've already had at least 3 months of symptoms by the time they present, don't wait for the blood results. Because if you wait for the blood results, then you're going to delay. You can see if they've already got established disease, the sooner they get seen, the sooner they're going to get put on disease-modifying anti-rheumatic drugs, the more chance that we have of reducing long-term damage. Okay. But this is about knowing the guideline and reading the fact that hands and feet, the small joints, were affected. Alcohol history. So this is another area that's been highlighted by the examiners. So let's see what people thought. Great. So A, hardly anyone picked. All of the others have been picked by lots of people. So the correct answer is E, 27 units. Now, there's 2 ways that you can do this. So one is, if you learn how many units are in common drinks, then you just have to count, and you could sort of multiply in your head or use a calculator. So if you know that a large glass, 250 mils, a large glass of wine, is usually about 3 units, okay, then what we do is we just need to count how many glasses she has in the week. So look, she has 1 large glass every night, 7 nights a week. So that's 7 glasses so far. But on Saturday and Sunday, she drinks another large glass with lunch. So how many in total? 9. Everyone see that? 7 from the evening. Each evening she has 1, 7 nights a week. But then on Saturday and Sunday at lunch, she has another one. So 7, 8, 9, right? So 9 times 3, 27. That's the shortcut. Really easy way to do it, okay? The other way is to use the formula. So the formula is units of alcohol is volume in milliliters, so 250 milliliters, times percentage alcohol by volume, 12% alcohol by volume, divide by 1,000. So look, 250 in milliliters times by 12%, divided by 1,000, that gives you 3. And then multiply that by the number of glasses. Again, 9 glasses, 27. This just adds another step, okay? Now, a common reason to get this wrong is a lot of people pick 21 or 24 because they just see the 7 nights and they do 7 times 3, or they see 7 nights a week and it says on Saturday and Sunday, okay, and they just add 1 rather than 2, so they're counting 8, so they do 8 times 3. These are the common reasons why people will get this wrong, okay? So units of alcohol. If you can learn how many units are in common drinks, so wine can range anywhere from 8% to 15% plus, but quite common, about 12%, okay? For this level, a small glass, 125 mils, is 1.5 units. A large glass, 250 mils, is 3. Standard strength beer is usually about 3.5 to 4%. A pint of that's 2 units, roughly. Premium beers and lagers, a bit stronger. A pint's about 3 units. That's the same for cider. Then spirits are 25 mils of any spirit at 40%, which is the standard alcohol by volume of most spirits sold in the UK, is 1 unit. Sometimes this is described as a single measure or a single shot. But this is the formula if you want to be perfectly accurate, okay? Diabetes management. So again, this specific topic of initiating insulin and also calculating how much insulin to start them on has been highlighted by examiners. So two popular answers are B and D. Correct answer is B. Okay. So well done for all of you that picked that. Those of you that picked D, there are some situations where actually this would be sensible. We'll come to that in a second. So key thing here is we're already told, look, he's already on triple therapy, still got high HbA1c, and he's happy to start insulin. So this isn't about whether we should start insulin or not. It's which is the right form. Okay. So NPH is generally recommended as first line for a lot of patients and would continue the metformin. So NPH is a long-acting insulin. Typically, I would give this as a once daily in the evening, and then basically throughout the day, they're going to have a baseline, and they still have their metformin, and then see how they get on. If that's not enough, then you can put them on a twice daily regime with NPH. And you don't always stop all of the others. Sometimes you might keep one or some of the other anti-diabetic drugs, but it's often easier if you just keep them on the metformin to adjust the insulin, because you're keeping them on lots of other drugs. It makes it more complicated. And of course, the more drugs you're on, the more risk of interaction, side effects, and so on. Okay. So when would we consider NPH and the short-acting insulin straight away? Because if this isn't enough, you might then add a short-acting insulin like around each mealtime. You'd consider that if their HbA1c is already 75 millimoles per mole or more. His was 70. Okay. Do you see? And then when would you consider something like detamir or glargine instead of NPH? If the patient can't do the injections themselves, they need help, or if what you put them on first, they get recurrent symptomatic hypos, or what they're already on, they're getting a history of recurrent symptomatic hypos, okay, then this might be a better option. Neither of those was mentioned in this scenario, so they wouldn't be the first line, okay? And then, when you've got them on this regime, you monitor their blood sugars, typically once in the morning, once in the evening, because you want to monitor. If their control isn't good, you might then need to change to adding in a short-acting insulin around meal times, okay? Type into the chat what answers you put. Okay, great. So quite a few of you actually had this. Great, 41,560. By the way, this is the only thing that will get you the mark. It's okay if you omit the comma. If you just put 41560, you'd get the mark. If you added to that per million, you'd get the mark. That's okay. But the number must be 41560. You would not get any mark for 4%, 4.1%, 0.41%, 0.041%. You wouldn't get any mark for 0.00415639, which is the first part of the calculation. You wouldn't get a mark for 41,560.39, which is the exact answer. Why? Because the question says type it to the nearest whole number. Do you see? It doesn't say, and it says per million. It doesn't say what is the incidence without specifying in what form, or it doesn't say what is the incidence in percentage. So if you put any percentage down, you won't get the mark. All right? It's really important to know how free text questions are marked. You see, in free text questions, hard because there's no options to guess from. All right? So this is, again, using real life population data collected. This was actually at the end of the first year of COVID that this data was collected. Okay? So incidence is the rate of new cases of a disease. All right? There's two ways we report it, either as a percentage or as a rate of whatever you're looking at as a proportion of the population. You have to remember that even a percentage is a rate, because percent just means per 100, that's all. Do you see? Whereas here we're looking at, instead of per 100, per million. Why? Because for incidence, because of how many people are getting it, okay, this is the common way worldwide. If you look at all of the data out there, this is how incidence is reported, is per million. That's why it's standardized. Okay. So first of all, calculate the incidence. So we take the number of cases, 2770, so that 2,770,000 cases in that year. Okay. And you divide it by the total population. That's the total population. This number is irrelevant. This number would be relevant if we were looking for COVID-related mortality. The question asks for incidence of COVID-19, not of mortality. Okay. So that gives you this number, 0.0415639. Now, if you wanted to turn that into a percentage, you'd multiply by 100. So it would go to here. It'd be 4.15 0.6039%. Okay, do you see? But we don't want it per 100, which is what percent means. We want it per million. So we need to now multiply this number by a million. So that gives us 41560.39, but it's set to the nearest whole number. So to round, what you do is after the dot, you look at just the first number. If this number is 4 or lower, this is the number you round to. Okay, you round down. If this number was 5 or higher, you'd round up to 41561. That's how you round to the nearest whole number. Okay, so that's incidence, rate of new cases of a disease, either as a percentage or proportion of the population. Usually we'll look at this over a year, okay? But you could look at over 5 years or 10 years, but usually it's over a year. So for example, 1% per year means 1 per 100. That's what percent means, okay? But you'll see that for a lot of things, it's quite common to describe it as a number per 1,000 or per 100,000 or per million, okay? So all you do, number of new cases, existing cases doesn't matter, new cases, divided by the total population. If you want it as a percentage, the second step is multiply by 100, because percent means per 100. If you want it per 1,000, multiply by 1,000, per 100,000 by 100,000, per million by a million. Whatever you want it per, that's the last step, okay? You multiply by that. Okay, and the last one, okay? So, and then I apologize, we're running a little bit over. I just need 10 minutes after this and we'll finish. So nearly everyone's got this right, which is great. Nice way to finish, okay? So key thing is this is negatively framed, and you'll see this in negatively framed questions, that sometimes the negative word will either be in bold or sometimes capitalized or underlined, okay? So essentially we've got someone been on diazepam, coming off, okay? And now they've got a shoulder sprain. So what's the least suitable analgesic regime? i.e. not what should you give, what shouldn't you give, okay? So the correct answer is codeine phosphate, okay? Why is that? Because if someone's already on diazepam, if you give them an opioid on top of that, there's a risk of respiratory depression, coma, even death, okay? And there was a recent MHRA alert about this, and that these are often tested in looking at safe prescribing, that you should avoid prescribing opioids for someone who's already on benzodiazepines because they don't mix well, okay? If it's absolutely necessary, you'd give the smallest dose for the absolute shortest duration and you'd monitor, okay? So add up your score, you get a number out of 15. You don't have to tell me, but to give you an idea, if this were the exam, we only did 15 questions, the exam's 200, but if you were doing the actual exam and you'd scored 11 out of 15, that would be a pass, even when it's been the highest, which has been 72%, was the highest the pass mark's ever been for AKT, okay? The last exam was 71.36 because one question had to be discounted. One of the clinical questions had an error, okay? So it's out of 199. 10 is borderline. It'd just be a pass in some sittings. It'd just be a fail in others. 9 or less, don't worry. I'd worry if you were sitting the exam tomorrow, but you're not. The earliest you're sitting it is 7 weeks away, which is a huge amount of time. The bulk of your revision is going to happen in these next 7 weeks. Do you see? Like you should have made a start by now, but a big chunk of your learning is still yet to come. So don't worry. I'd worry if you were at this level the day before the exam, but you're not. But hopefully I've helped you by covering some of these key topics mentioned by examiners and doing hard questions. Identify that, look, it's not just that I've got to put the work in and learn the stuff. I've got to read the question carefully. I've got to watch out for some keywords that might change the right answer. I've not got to make sure I don't make careless mistakes, because then I might have put the work in, but I could still lose some marks here and there, and they can add up. And hopefully we've helped you also identify some gaps in your knowledge to go away and do that work, okay? So in terms of revision planning, these last 7 weeks, you should have already covered a good chunk of the curriculum, but I don't expect anyone to finish covering the curriculum at this stage. You should still have, a lot of time left to do things. So what you want to do is systematically cover any gaps and make sure that any weaker areas in the curriculum, you allow enough time, because often some of the weaker areas, you might need to read it more than once because it's weaker because maybe you haven't done a job in it, or you've always avoided it, or there's some topics that we all find particularly challenging. It's different for all of us. Some things that will really help, make sure in the last sort of 6 weeks or so, this last period coming up, that you do revise all the key stats and admin topics, and that you've got to cover all the clinical topics at some point, but make sure you go over more than once the high yield clinical topics, those topics that were mentioned by the examiners. Why? Because look, this gives you 10% of the exam, this gives you 10% of the exam. Covering the high yield clinical is probably going to give you another 20% of the exam. So you're nearly halfway there by making sure you go over these things. If you're not already part of the GP training support group, the eMedica GP training support group, make sure you're joined, because the last 30 days before the exam, I will post one high yield question every day with a rapid revision and a review. Typically, they only take 5-6 minutes to do, okay? But every day, if you do it, without realizing, you cover 30 important topics. And then work on your exam technique. Keep practicing online questions. Read up on topics you get wrong, and make sure you do some timed mock exams to make sure you get used to that exam pressure, covering lots of topics, concentrating for a long time, okay? In the post-course reading that I will send you, I'll send you out an email with some links. I'll send you a link to the latest version of our high yield topics checklist. This is only part of it, it's not the whole thing, but essentially I read every examiner's report, and I've read every examiner's report ever since the first AKT in 2007, okay? And what I do is I pick out what are the actual topics and make it as a checklist. So it's easy for you to print it, stick it on a notice board, tick them off. Really interesting. In the last examiner's report from the January exam, there wasn't a single topic the examiners mentioned that people struggled with that wasn't already on my list. That's how often they're repeated. If we look at the last 3, from the 30 topics they mentioned, the last 3, there are only 1 or 2 new topics. So you can download the latest one. Those of you that are on our AKT Pass Guarantee program, you've already been sent the latest version, okay? You already have access to that, okay? But I'll send it out to all of you anyway, in the post-course reading, which will come out in the next couple of days. So in terms of reading guidelines, if there's a specific guideline that you want to read, NICE or the NICE CKS are useful for that. If you want to cover lots of them in a very concise way, you might find helpful our clinical case cards. So we're on the 8th edition now. They're mapped to the same thing the questions are mapped to in the exam. And we've taken these from NICE or other published national guidance, but made it really, really concise. So you just pick up the key topics, and where relevant, there's high quality pictures that we've licensed to use, that fit, okay? And so these were 8th edition. They were updated right at the end of 2021. So, they're up to date for your current exam, okay? You can see, for example, COVID-19, SARS-CoV-2 added, things like the orbit bleeding risk score for AF was updated late last year, summer last year, for example, okay? So we have a printed version, we have a digital version, or there's a bundle where you get both the printed one and the digital one at a discount. You can see details here. And then if you found how we learned there doing a mock exam, I know it was mini, it was 10 questions. If you found that helpful, and then going through the answers and teaching, well, we use that type of learning in both our AKT 200 question crammer course, which is happening on the 26th of March. We'll do a 50 question rather than 10 question one, then go through the topics, then a break, then another 50, then a break. By the end, we've covered 200 questions, 200 topics. You'll get a booklet with all of the learning, and then you get access to a different full 200 question more, 200 different questions afterwards, okay? So that is available, the AKT 200 on the 26th, as well as all 4 webinars, the stats, admin, and 2 high yield clinical, as part of what's called our booster bundle, okay? So you'll save over £150 if you buy that. You don't need any code, okay? If you just want all of the webinars that we talked about earlier, stats, admin, the 2 clinical, again, if you get all 4, you will save money compared to buying all 4 separately. And then we do have our Pass Plus bundle, which includes all of those, but also our full day AKT preparation course. This is our flagship AKT course. That's happening this Saturday. So this has a mix of both. We have 3 teaching mini mocks on the day, a full mock afterwards. We have some coverage of key admin topics, stats topics, lots of clinical topics, but also a big focus on exam techniques, understanding and interpreting keywords. But this bundle also includes the printed clinical case cards, over 2,600 online questions, 3 full mocks, at a discounted price. Okay, so someone in the team will post the links to all of those. Those of you on a Pass Guarantee program, you're already attending all of these and more. So don't worry, you don't need to book anything. Okay, so any questions, type them in the Q&A. But what I will do is I will finish now for those that haven't got questions, just with a real important message. And that is, look, 7 weeks is still plenty of time. What I want you to do is focus on the effort and on the work. Don't count the days. Don't panic, make the days count. 7 weeks is a lot of time, but you've got to make every day count, because if you don't actually have a plan, if you don't have some structure to learning, and you don't put in some effort every day, what you'll find is, we're busy. We've had a busy day at work, you've had an on-call, you've had a couple of things going on, weekend, you need some time off, right? You're shopping, got to do stuff with the kids, without realizing the days go by. And if you don't make every day count, 7 days can seem really short. But if you make the effort and you make every day count, you do something every day, let me tell you, I promise you 7 weeks is a huge amount of time. And come the exam, you will be ready and you will smash your exam. Okay. So, thank you very much. Huge thank you for the team for supporting the webinar and answering all the questions. Thank you for everyone for being patient with me and staying back so we could actually finish and giving up part of your evening, to engage in learning. I hope you found this helpful. I hope to see, I know I'm going to see everyone on the program this weekend, and I'm going to see a lot of you. We've got a lot of AKT courses happening in March, okay, and all of the different webinars. So I'm going to see a lot of you at, different things. But whether I see you at those or not, if you found this helpful, and you might just use some of our free things like the free learning, we also have some other free learning on our YouTube channel. I'll be posting more things into the Facebook group as well. I hope that you found it helpful. And just remember, keep pushing, keep going, prepare, and you will succeed. Thank you so much, everyone. Have a great evening and all the best with your exams.